right, so welcome to this infectious disease review. This is going to be a high-yield walk through infectious diseases by looking at the Rosh blueprint and the Rosh guide. And so it's designed to be quick, concise, and PANCE focused. So let's go ahead and get started. Here's just a quick overview of what we're going to cover. So we're going to start with bacterial disease, then move to fungal disease, mycobacterial disease. We'll talk about some prenatal transmission, sepsis and SIRS, spirochete, and viral diseases is how we'll round it out. So let's go ahead and start off with botulism. So botulism is caused by Clostridium botulinum, and this is an anaerobic spore-forming bacterium, produces a neurotoxic blocking acetylcholine release. And this is going to be at the neuromuscular junction, and it's going to lead to a flaccid descending paralysis. So this quick area is going to look at infant botulism. It's most commonly caused again by Clostridium botulinum, and the patient's going to be an infant with a history of ingestion of honey, and we're looking for a feeble cry or a poor feeding, constipation, and the classic floppy baby. Okay, in adults, so botulism, just think of home canned food. Canned food is a big thing in the vignettes that we're looking for. Patients are going to develop that blurred vision, ptosis, dysarthria, dysphagia, and a progressive weakness that descends, so descending symmetric paralysis towards respiratory muscles. On physical exam, we're looking for symmetric descending paralysis with the preserved sensation. And then on diagnosis, it's mainly clinical, but we're going to do stool and serum toxin assays for confirmation. And then as far as management, we want to give that botulinum antitoxin immediately in adults and use the botulinum immunoglobulin or baby BIG for the infants. Okay. And we're going to provide airway and supportive care, airway support as needed for these patients. Appropriate tip: never give honey to infants under the age of 12 months. This is the most preventable cause of infant botulism. And all cases are required to be reported to the CDC. All right, next up we have Campylobacter Jejuni. This is a gram-negative curved rod, and it's spread by fecal oral route. And it's most commonly comes from undercooked poultry, unpasteurized milk, or contaminated water sources. The patient is often going to report this recent chicken consumption, raw dairy, or swimming in untreated water. And symptoms are going to include this fever, nausea, abdominal pain, frequent bloody diarrhea. And the pain can mimic appendicitis due to the right lower quadrant cramping. Diagnosis is going to be confirmed by stool culture, and management is primarily supportive. So we want to rehydrate with electrolytes, and in severe immunocompromised cases, we'll treat with a macrolide like azithromycin. Appropriate tip here is a patient with bloody diarrhea followed by an ascending weakness. You want to think Campylobacter triggering Guillain-Barré. And this is a classic PANCE connection. Remember, reactive arthritis and Guillain-Barré are potential sequelae of this. Okay. Moving on to chlamydial cervicitis. So now we're going to talk about a few things that chlamydia causes. So chlamydia cervicitis is most commonly caused by Chlamydia trachomatis, and it's an intracellular organism transmitted through sexual contact. Often it's asymptomatic, but patients can report some vaginal discharge, dysuria, or even pelvic discomfort. Diagnostic testing, we want to use the NAT, or the nucleic acid amplification testing, and this is considered the gold standard. Management can be with that single dose of azithromycin or doxycycline for 7 days, but you want to look at your local resistance patterns for this. As far as treating empirically for gonorrhea, if the patient is at higher risk for having concomitant diarrhea, we can empirically treat for that as well, since the co-infection is common. And then the USPSTF recommends routine screening for all sexually active women under the age of 25 and for older women at increased risk. Appropriate tip: if you treat chlamydia, never forget gonorrhea. So you want to either test for it or double cover for that. They just love to travel together, gonorrhea and chlamydia. Okay. Let's go on. chlamydial conjunctivitis is next up. So we've talked about this in the EENT review before, but as a quick recap, we see it in neonates between 5 and 14 days, so a little later than gonorrhea. They'll present with a mucopurulent eye discharge, eyelid swelling, and red conjunctiva. It's the same organism as the cervicitis, the Chlamydia trachomatis, but this time it's delivered via vertical transmission during delivery. Management, we want to treat with oral erythromycin, not topical. This is to cover for concurrent pneumonia. Now, appropriate tip, always think of Chlamydia trachomatis when a newborn develops conjunctivitis in the second week of life. Remember, gonorrhea tends to hit earlier within the first 2 to 5 days. Let's talk a little bit about neonatal chlamydial pneumonia. So it's most commonly caused by Chlamydia trachomatis again, and this infection typically appears between 3 and 16 weeks of age. And the presentation is usually an afebrile baby with cough, hoarseness, and malaise. And on exam, you want to listen for distinctive staccato cough, which are very short cough bursts, and they're short and repetitive. And the management, we're going to treat with a macrolide, such as erythromycin or azithromycin. And appropriate tip here is remember the triad: conjunctivitis, staccato cough, and no fever. That is usually neonatal chlamydial pneumonia until proven otherwise. All right. Next up is psittacosis. Anytime I think of the word psittacosis, I think of birds, okay? So psittacosis it's another chlamydial infection, but this one's caused by Chlamydia psittaci, and this is linked to bird exposure, especially things like parrots, pigeons, or poultry. And the presentation, the patients are going to have this high fever, severe headache, myalgias, and a non-productive cough. And on exam, you might find some hepatosplenomegaly. Chest X-ray is going to show a patchy perihilar or lower lobe infiltrate, and we want to manage with doxycycline. This is the treatment of choice. So just think birds. I always see the word psittaci or psittacosis, and I think parrot for some reason, because parrot has the letter P in it as well. And if a patient presents with pneumonia and a clear history of like cleaning bird cages or owning parrots, you want to think psittacosis every time, at least initially. All right, now that we've covered the chlamydial bacterial illnesses, let's talk about cholera. So this is caused by the bacteria Vibrio cholerae, and it's a gram-negative bacterium transmitted through contaminated food or water. And the patient's usually going to be someone with recent travel or exposure to the contaminated water source while on their vacation or trip. And they're going to present with this profuse watery diarrhea that's classically described as rice water stools. And they're going to be kind of whitish to grayish coloration, thin, gray, and they're going to be flecked with mucus. And this leads to severe dehydration and hypovolemia. So with these patients, we really need to watch their hydration status. Diagnostic studies are going to include a stool culture, dark field microscopy is going to help us confirm the diagnosis. And management, the cornerstone is going to be aggressive fluid resuscitation. We usually use lactated ringers in more severe cases, but we just got to get them full of fluids, okay? They're going to be very, very dehydrated. And so antibiotics can be considered like fluoroquinolones, macrolides, tetracyclines, especially in the more moderate to severe cases. We can consider that. Appropriate tip is always remember that in cholera, fluid replacement saves lives, and antibiotics are kind of like a secondary thing or for more moderate to severe cases. All right, diphtheria, one of the kiddo illnesses that we vaccinate for. So diphtheria is caused by Corynebacterium diphtheriae. That's anaerobic, gram-positive bacillus that produces an exotoxin causing local and systemic effects. And so the presentation, we're going to see an upper airway illness with sore throat, low-grade fever, thick gray pseudomembrane covering on the back of the pharynx or on the tonsils. I call this my cornflake throat. Okay, so you'll look back there, you'll see this big old patch of disgustingness, a pseudomembrane in the back of the throat. So on exam, you might also see some of these other findings. So you might see this bull neck or classic, cervical adenopathy. They might describe the pharyngeal coating as grains of salt or cornflake throat. I always think of cornflake throat. And some of the other complications associated with this is myocarditis and neuropathy from the circulating toxin. Management includes diphtheria antitoxin and erythromycin or penicillin. An appropriate tip is if you ever see that gray pseudomembrane that bleeds when you scrape it off, you want to isolate this patient immediately and we want to start the antitoxin. All right, let's move on to hemolytic uremic syndrome, which is most commonly caused by E. coli 0157H7. So I think of that as the E. coli with all the letters and numbers, right? So hemolytic uremic syndrome is most often caused by this. It produces this Shiga-like toxin, and this leads to microangiopathic hemolysis and a renal injury. And so that gives us the classic HUS triad of hemolytic anemia, thrombocytopenia, and renal insufficiency. So presentation is going to be usually starting with some sort of bloody diarrhea, and then it usually follows eating of some sort of uncooked beef, unpasteurized juice, or contaminated produce. I always think of Jack in the Box from the outbreak back in the day that killed some kiddos. And there's a really good documentary called Netflix, doc Poison, the dirty truth about our food. So that I would go ahead and give that a quick watch. It puts it into perspective. As far as diagnostic findings, we're going to see those classic things: the anemia, thrombocytopenia, and acute renal failure, and that's the classic HUS triad. As far as management, some really specific important things. It's strictly supportive. So we want to give fluids, we want to monitor closely, and even do dialysis if needed, but we want to avoid antibiotics because they can increase the toxin release and actually worsen the condition. Appropriate tip is HUS follows bloody diarrhea in kiddos. So when you see anemia plus thrombocytopenia plus renal failure, think E. coli 0157H7 and do not give antibiotics. All right, let's move on to gonococcal urethritis. This is the long lost cousin of the chlamydial cervicitis, right? So gonorrhea or gonococcal infections are caused by Neisseria gonorrhoeae. This is a gram-negative diplococcus. It's transmitted sexually or perinatally. And in men, the classic finding is going to be a purulent urethral discharge and some dysuria. And women might have cervicitis, pelvic pain, or they could even be asymptomatic. Diagnosis is really confirmed by urine culture showing that gram-negative diplococci or by PCR testing, which is both sensitive and specific. As far as management is concerned, we can give a single dose of ceftriaxone 250 IM, and then this is plus azithromycin, but I've seen it go for the doxycycline for better coverage for the chlamydial co-infection. We always want to treat gonorrhea and chlamydia together. If you remember to test or you come across one, should probably think about double covering for that. All right. As far as these other gonococcal infections, so think of things in men like urethritis, epididymitis, prostatitis, pharyngitis, conjunctivitis, women, cervicitis, PID, pharyngitis, conjunctivitis. You can also get disseminated infection and think of septic arthritis and things like that. All right, moving on to MRSA, methicillin-resistant Staphylococcus aureus. So this has developed resistance to the beta-lactam antibiotics we know, and this is called MRSA. It can cause a range of infections from things like skin infections to soft tissue abscesses and pneumonia, and even bacteremia. So management for this is going to be, well, for minor infections, we usually tend to use Bactrim or trimethoprim, sulfamethoxazole, clindamycin, or doxycycline. For more severe systemic infections, we're going to use vancomycin or linezolid. Appropriate tip, so any abscess with pus, you want to think MRSA until proven otherwise. All right, moving on to rheumatic fevers. This is usually post-streptococcal. Rheumatic fever follows that infection of group A streptococcus or strep pyogenes, and it's an autoimmune response. It affects the heart, the joints, the skin, and the brain. And the presentation is often going to be this fever, red skin lesions on the trunk or proximal extremities, and small non-tender subcutaneous nodules over the joints. And we want to remember the Jones criteria. So on physical exam, we're looking for these criteria, JONES. So we're looking for the joints is the J. That's migratory polyarthritis. We're looking for O, that's carditis, so myocarditis. Then we can look at nodules, so subcutaneous nodules we usually see, or on the extensor surfaces. Erythema marginatum, which is a special rash that they can get. And then the Sydenham chorea, all right, that's a neurologic finding. As far as diagnostics, elevated ASO titers, anti-DNase B, or a positive throat culture. And treatment's going to be NSAIDs for the inflammation and antibiotics, typically penicillin. Appropriate tip here as far as the Jones criteria. You can have 2 major or 1 major plus 2 minor criteria to confirm a new rheumatic fever episode. So we want to keep the Jones criteria at the front of our mind for our PANCE exam. Okay, and here's that revised Jones criteria. 2 major criteria or 1 major, 2 minor. So these are the ones we're looking at there. Okay. Let's keep going. So next up we have Rocky Mountain Spotted Fever. This is most commonly caused by that Rickettsia rickettsii, and we're going to look for usually camping or hiking. And Rocky Mountain Spotted Fever is transmitted via the dermacentor tick, and it's most common in the southeastern United States, especially North Carolina. So we'll see a patient often with recent hiking or camping history, and presentation is usually an abrupt onset of severe headache, fever, myalgias, nausea, and vomiting. On physical exam, we want to look for that classic maculopapular rash that starts on the wrists and ankles and spreads to the palms, soles, and trunk. And on diagnosis, we'll confirm it with a skin biopsy, but we don't want to delay treatment to get this biopsy. As far as management, doxycycline is usually the treatment of choice, even in kiddos. So here's kind of that endemic area. Here's that dermacentor tick, and the most common places that we see it. All right, so moving on to salmonellosis. So this is caused by the Salmonella species. It's often transmitted via poultry, eggs, or meat, and occasionally from turtles, the cute household pets, Ninja Turtles. So presentation, we're going to see fever, bloody diarrhea, abdominal cramping, and the diagnosis is usually made by fecal WBC, so high WBC count, and that's usually associated with the bloody type of diarrhea. Complications. So in kiddos with sickle cell, salmonella is the most common cause of osteomyelitis. So we want to keep that in mind. A lot of times they'll put that in a vignette. So we want to think that salmonella osteomyelitis whenever we get a sickle cell child who presents with bone pain and fever. And then we're going to give Cipro in severe illnesses. All right, moving on to Shigella. So Shigella is an infection which typically presents with fever and bloody diarrhea, and usually mucoid in nature. They also have seizures that are pretty common in kiddos. Diagnostics are going to be via fecal RBCs and WBCs on stool study, and then treatment, we're going to give Cipro. That's what's most commonly used. We also need to give fluids and electrolytes if they're dehydrated. It can also include a hemolytic uremic syndrome and reactive arthritis because it's Shiga-like. And so it hits pretty hard and pretty fast. We want to think high fever, seizures, bloody stools in kiddos, and then treat them accordingly. Tetanus. So tetanus is, well, everybody knows what tetanus is. Everybody's gotten the tetanus vaccine before. So it's caused by Clostridium tetani, and this releases that neurotoxin that causes the muscle rigidity and the spasming. And presentation usually begins with trismus or lockjaw, and then progresses onto that generalized muscle rigidity and descending paralysis. So we manage it usually with benzodiazepines to help with the spasm control. We also give metronidazole, but not penicillin, plus the tetanus immunoglobulin, and we want to do routine immunization to prevent this from happening. We want to make note that the strychnine poisoning can mimic tetanus, and if you see muscle spasms after a wound, we want to treat first and don't wait for the test results. Okay, here's the lockjaw, the tenatospasm, so lots of spasming, and then that's the rhisis sardonicus, which is that smile that they get with the spasming of the face. All right, and then here's the immunization for tetanus prophylaxis. If they've had prior immunization greater than or equal to 3 doses, and they have a low risk wound, you can update their booster over 10 years. If they have a high risk wound and they've had greater than 3 doses, if it's been 5 years, you want to update. If they have uncertainty, then that's when we need to give the vaccine or give it with the immunoglobulin. All right. That was our quick look at the bacterial diseases. So now we're going to move on to some of the fungal diseases, including candidiasis. So we're going to see candida in multiple places. First off, we're going to talk about oropharyngeal candidiasis, or thrush. This is caused by Candida albicans. It's a yeast, part of the normal flora of our system, but it becomes pathogenic when we have local immunity, or the immunity is disruptive, or we have a neonate. And so the patient's often someone with an inhaled corticosteroid or recent antibiotic use, or if they're immunocompromised or suppressed. On physical exam, we're going to have those white curd-like plaques on the oral mucosa that can scrape off, and that leaves that erythematous base underneath. And treatment, we want to use oral nystatin or oral fluconazole for more extensive disease. So appropriate tip is to remind our patients to rinse their mouth out after they used inhaled steroids, and this is to prevent thrush. We also want to consider this in post-antibiotics. So like if we just gave them recent antibiotics for another type of infection and we see this, that's what it probably is. Moving on to a different type, we have vulvovaginal candidiasis. This is also caused by Candida species, most often Candida albicans. The patient may have a history of diabetes or HIV or recent antibiotic use, and they present with intense vaginal itching and burning with urination or with intercourse. They have that thick, white, cottage cheese-like discharge, and their vaginal pH is usually less than 4.5. And on exam, you'll see the pseudohyphae or spores on microscopy. Treatment is with the single dose of fluconazole or the topical azoles. Appropriate tip, if the pH is normal and the discharge kind of looks cottage cheesy, it's Candida until proven otherwise. Okay. Moving on to candidal diaper dermatitis. So this occurs in infants due to prolonged moisture, like diapers, wet diapers in the diaper region. On exam, we're going to see that beefy red plaques, often in the inguinal folds and along the genitalia, with those classic satellite lesions. So leading away from the large patch of red, these little red spots there. Treatment is going to be topical nystatin or clotrimazole. And in diaper rashes, the satellite lesion is going to give it away. That's always Candida. All right, Cryptococcus. So this is an opportunistic fungal infection. It's seen mostly in HIV positive patients, especially when the CD4 count is below 100, so more immunocompromised. They're going to have this headache, fever, stiff neck, photophobia, and sometimes vomiting. And this is pretty consistent with fungal meningitis. For diagnosis, we're going to do an India ink stain of the CSF, and they're going to see round encapsulated yeast. And we can also do the cryptococcal antigen in CSF or in the serum, and that's confirmatory. Management, we're going to use the big guns here. We're going to use amphotericin B plus flucytosine for induction, followed by fluconazole for maintenance. And so appropriate tip for this is if you have that positive India ink stain plus encapsulated yeast, it's Cryptococcus, and always think of it in an HIV patient with meningitis. Next up is histoplasmosis. So it's one of the usually fungal lung infections that we have. It's caused by Histoplasma capsulatum, and it's found in bird and bat droppings, especially in the Ohio or Mississippi River Valley. So I always think of Ohio. It has the word Ohio in here besides the O. Histoplasmosis is how I remember it. And the patient often has a recent travel history or cave exposure in those endemic areas. On diagnosis, we're going to do a chest x-ray. It's going to reveal that solitary pattern or calcification in the hilar or mediastinal lymphadenopathy. And then we're going to use itraconazole or amphotericin B for severe cases. So if you have a patient with Ohio River Valley, bat caves, bird droppings with fungal pneumonia, you're going to think histoplasmosis. Next up is Pneumocystis jirovecii pneumonia, formerly known as PCP pneumonia. And this infection is most common in HIV positive patients with a CD4 count under 200. Gradual onset of non-productive cough, dyspnea, fever, and the physical exam might show some hypoxia and rales, non-productive cough. And diagnostics, we're going to get a chest x-ray. It's going to show that bilateral diffuse infiltrates or bat wing pattern, and LDH is typically elevated. We want to treat with Bactrim or trimethoprim sulfamethoxazole. That's the drug of choice. So a tip here is if you have a CD4 count less than 200 in an HIV patient, you want to prophylax with trimethoprim sulfamethoxazole to prevent PJP. And there's that classic bat wing pattern on x-ray. All right, those were the quick fungal stuff. So now let's move on to mycobacterial infections, okay? We're going to start with atypical mycobacteria, and these are environmental organisms that can cause like TB-like or skin infections, especially in immunocompromised hosts. And we're talking pretty severely immunocompromised. The MAC, or Mycobacterium avium intracellular, it affects patients with a CD4 count less than 50. And it has a TB-like illness, a disseminated TB-like illness. There's some other ones. There's the Mycobacterium kansasi, and that's a TB-like illness. There's a Mycobacterium marinum. That's fish contact, skin lesions, lymphadenopathy in like an aquatic environment. And then there's the Mycobacterium ulcerans, which ulcerative skin lesions, rural topical environments. I would just be really vaguely familiar with this. You don't got to go take a deep dive into it, but just know that it exists. Look for that CD4 count in an HIV patient, especially someone who's not on, heart therapy consistently. All right, pulmonary TB, very, very important topic. We've covered it in our pulm review, but basically some quick hits. It's caused by Mycobacterium tuberculosis, transmitted via airborne droplets. Patient often has a history of being immunocompromised, being born in another country, an immigrant living in close quarter conditions like incarceration. And we want to know the difference between primary or latent TB and reactivation TB. So it might be asymptomatic or show kind of low-grade fever and malaise initially. And a chest x-ray is going to reveal that gone focus in the mid or lower lungs for the primary TB. The diagnostic test is going to be PPD. The TB test is going to be the gold standard for screening, and treatment is going to be that isoniazid for 9 months with B6 to prevent neuropathy. If we have reactivation TB, which is what we see way more often, they're going to present with fever, night sweats, weight loss, and chronic productive cough, and sometimes hemoptysis. The chest x-ray for these is going to show cavitary lesions, usually in the upper lobes. And diagnosis is going to be via sputum smears for acid-fast bacilli. And that's what's going to confirm it. 3 different samples in the morning. And then treatment is going to be the classic RIPE therapy. So that's going to be rifampin, isoniazid, pyrazinamide, and ethambutol. We also need to know PPD interpretation. Here's those medications. You need to know the TB meds. You need to know the side effects of the TB meds. And then we also need to know the treatment. Sorry, let me go back. This right here. So positive PPD testing. So anyone with greater than 15 millimeter test is positive, and doesn't matter who you are, you're positive at greater than 15. At greater than 10 millimeters, it's going to be in the high risk groups like homeless, healthcare workers, IV drug users, foreign born people. And then 5 millimeters is going to be the most immunocompromised, recent TB contact, abnormal chest x-rays, transplants, things like that. Be sure to know this is very highly testable material, and also really, really know the RIPE therapy. Let's keep going. This is, of course, the primary TB that we were talking about with the Gon complex. And then this is going to be the reactivation TB, usually in the apices or the upper lobes, and cavitary lesions most often. Okay. Now we're going to talk about miliary tuberculosis. So miliary tuberculosis is when TB spreads through the blood, and it forms like countless small little granulomas throughout the whole body. It's usually in the elderly or in a patient with a history of HIV. We're looking for that fever, weight loss, fatigue, and weakness. And chest x-ray is going to show that diffuse millet seed pattern throughout the lungs. We also might see that hyponatremia sometimes from the development of SIADH. And this is kind of the pattern on x-ray. It looks like little millet seeds throughout. Here's that. That was what I was looking for. Here's the TB skin test. You absolutely have to know this. So take the time to read through this and memorize who is positive at what millimeter in duration. And then this is just the difference between the TST or the tuberculin skin test and the IGRA, the pluses and the advantages and disadvantages of both. You should just look over this. All right, finished up those. Now we're working on some of the parasitic diseases. So first off, let's start off with the hookworm. So the hookworm is most commonly caused by Necator americanus, and it's transmitted when the larvae penetrate the skin, often the feet, and then they migrate to the small intestine. So the presentation might include intermittent diarrhea, cough, or pruritic rash at the entry site. And lab findings, think eosinophilia. They also might have a hypochromic microcytic anemia due to blood loss. And you'll want to see that classic rash. It looks like a worm under the skin. Look for that. And then think about it in kiddos, like in sandboxes or things like that. The treatment is going to be an albendazole or mebendazole. Okay. Next up is amoeba liver abscesses or Entoamoeba histolytica. That's the type of amoeba that causes this, transmitted usually by fecal oral route. Patient may have a history of camping or travel to the Midwest or the tropics, and they'll have this right upper quadrant abdominal pain, bloody diarrhea, and abdominal tenderness. And treatment's going to be with metronidazole. Okay, so this is kind of the progression of the different things that can happen with it. Ascariasis is caused by Ascaris lumbricoides, and it's a roundworm. Most common human helminth infection worldwide, caused by ingestion of the roundworm eggs. So the patient often presents with a history of recent travel or exposure to poor sanitation, and the presentation is a cough with wheezing, abdominal pain, and diarrhea. And that the larvae migrate through the lungs and the intestines, and then they get into the GI tract. And they become adult worms there, and then they cause a worm burden where there's just so many in there that they tend to block the bowel or even the biliary tract. So we want to get stool studies for OMP, and we'll treat with albendazole. Appropriate tip here is pulmonary plus GI symptoms together. We want to think Ascaris migration. Giardiasis. So Giardia lamblia is transmitted usually by contaminated lake or stream water. It's classic on camping trips, so look for that in the vignette. Presentation: explosive, foul smelling, non-bloody, and greasy diarrhea, along with bloating and flatulence. The stool exam is going to show that flagellated prozoa, so they're swimming around, or you can have a positive antigen test. And we want to treat with metronidazole or Flagyl. So think about that when you're looking at those vignettes. It can also be passed through daycare, but I often see it more in the streams or camping. Okay. And it stinks really, really bad, by the way. All right, malaria. So this is caused by Plasmodium species and is transmitted via the Anopheles mosquito. And a patient typically is a traveler or an immigrant from an endemic area, and they present with cyclic fevers, chills, and diaphoresis. And a diagnosis, we use the thin and thick blood smears, and that shows the parasite inside the RBCs. And there's a little picture of that down here. Treatment is going to be with chloroquine for the non-resistant areas and quinidine plus doxycycline for the resistant infections. So we always want to ask about travel, fever, in fever and cyclic chills, especially after travel. So think about malaria in those cases. And here's just the life cycle of the malaria parasite for the patho enthusiasts. All right, pinworms. If I see any, I see this one. This one's the one I see most often. Transmitted via the ingestion of pinworm eggs. Sounds great. Common in school-age kiddos. We're going to see the classic nocturnal perianal itching, and sometimes disturbs their sleep. And the diagnosis is made via the tape test, where you place the clear tape around the perianal area in the morning to visualize the eggs under the microscope. And treatment's going to be with mebendazole or albendazole for the patient and for the close contacts. So if you have a kiddo, especially a little kid with itchy bottom, think pinworms. And that's what they look like. Just a lot of fun. Toxo. Okay, so toxoplasmosis caused by Toxoplasma gondii. It's a protozoal infection spread by cat feces or undercooked meat. So it will often notice a patient, commonly HIV positive with a CD4 count less than 100, or a pregnant woman who's exposed to cats or cat litter. So they'll present with focal neurologic deficits in immunocompromised patients. Diagnosis, we want to use a brain CT or MRI, and it'll show those classic ring-enhancing lesions. So we'll want to treat with the primethymine plus the sulfadiazine plus folinic acid. And then appropriate tip is really pregnant women should never change the cat litter because of the risk of congenital toxoplasmosis. Now, cerebral toxoplasmosis are those typical ring-enhancing lesions. We often see these in the HIV-positive patients. We'll do the brain CT, it'll show those classic ring-enhancing lesions, and we'll manage them with those same medications. Again, pregnant women should not change the cat litter. And there you go. Trichomonas, see this a lot in women's health, in the ER, in primary care. So most commonly caused by the Trichomonas vaginalis species. It presents with a malodorous vaginal discharge, pruritus, and dysuria. The exam, you're going to look for that frothy greenish yellow discharge and the strawberry cervix, so red with little splotches on it. Diagnostics, we're going to use a wet mount. We're going to look at it under the microscope. We're going to see those motile, flagellated, pear-shaped organisms, and the vaginal pH usually hangs out above 5. So treatment is going to be metronidazole, and we want to treat the patient and the partner. And so if you see that classic greenish yellow frothy discharge in the strawberry cervix, think trichomonas. All right, the next few things we're going to talk about are the prenatal transmission disorders. So first we're going to start with congenital varicella. So this is after a maternal infection with the varicella zoster virus happens during early pregnancy. Complications for the baby can include limb hypoplasia, cutaneous scarring, eye defects, and neurologic abnormalities in the fetus. And so prevention is really key. Women of childbearing age should have documented immunity to varicella prior to the pregnancy. If you have exposure to varicella in early pregnancy, it can be devastating. So we always want to check varicella immunity before conception if possible. All right, next up we have neonatal herpes simplex virus. So this infection typically results from perinatal transmission during the vaginal delivery in mothers with active genital lesions of herpes simplex. So it can range from anything from localized skin lesions to eye or mouth lesions to disseminated infections and CNS, liver, or lung infections. And so we want to confirm by viral PCR culture prior to delivery if possible. And we want to manage with IV acyclovir promptly to reduce morbidity and mortality. So appropriate tip here is if a newborn develops vesicular lesions within the first 2 weeks of life, we want to think neonatal HSV and start acyclovir immediately. Next up is condyloma acuminata. So this is caused by HPV type 6 and 11, which are the non-oncogenic strains. And they usually present with a cauliflower-like wart on the vulva, vagina, cervix, or perineum. And treatment options include imiquimod, photophylline, or cryotherapy. And it's the most common STI we see. Most common sexually transmitted infection in the whole world. And so we're looking for those classic cauliflower-like lesions. Appropriate tip, condyloma acuminata, HPV type 6 and 11. They're benign, but they're still really important to treat and monitor. Another one we have here is HPV, so verruca plantaris or plantar warts. It's caused by HPV type 1. It causes these painful hyperkeratotic lesions on the soles of the feet with visible black dots, and those are thrombosed capillaries. We want to manage it with salicylic acid or cryotherapy for removal. And if you see those classic black dots, think plantar warts. Other cutaneous warts, these are also caused by HPV, but most commonly the strains are going to be types 2 and 4. And they appear as rough, raised, flesh-colored papules on the hands and fingers. They're usually self-limited, but they can be treated with cryotherapy or salicylic acid. And the common warts, again, HPV types 2 and 4. Remember that for exam questions. This is just the recommended doses and intervals for the HPV vaccine, which is one of the newer vaccines that we have on the schedule. But here you go. There's your HPV vaccines. Moving on to Zika virus. So Zika virus, there was an outbreak, about a decade or two ago. And this is an important virus that's transmitted via the Aedes mosquitoes, and it can also spread through sexual contact. So the major concern here is the congenital Zika syndrome, which can cause microcephaly and severe neurologic deficits in infants born to infected mothers. So the preventative counseling, if only the male partner travels to Zika risk area, we want to avoid unprotected sex for at least 3 months after they return. And if only the female partner travels, we want to avoid unprotected sex for at least 2 months. If both partners travel, we want to wait at least 3 months after return before attempting for conception. So, appropriate tip here is really Zika prevention is all about timing. Know the second and third month rules for counseling couples in planning for pregnancy. And here's some of the complications that can happen. All right, so next up is SIRS, so Systemic Inflammatory Response Syndrome. This is in relation to sepsis. So to be diagnosed with SIRS, you have to have 2 or more of the following criteria. You have to have a heart rate greater than 90, a temperature greater than 100.4 or less than 96.8, a respiratory rate greater than 20, or a PaCO2 less than 32, and a WBC count greater than 12,000 or less than 4,000 or greater than 10% bands. So those are the criteria to meet SIRS. So when SIRS is caused by a confirmed infection, we call it sepsis. And severe sepsis involves evidence of organ dysfunction like an elevated lactate, altered mentation, or hypotension. And septic shock occurs when hypotension persists despite fluid resuscitation. So there we have sepsis, severe sepsis, and from severe sepsis, we go on to septic shock. Management is going to be basically aggressive fluids, IV fluids, broad spectrum antibiotics. Within the first hour, we want to give those, and source control like removing infected lines or draining abscesses. An appropriate tip here is really the earliest life-saving step in sepsis is fluids and antibiotics. We got to do this fast, and in sepsis and SIRS, every hour counts. Next up, we have spirochetes. So spirochetes include Lyme disease and syphilis. Let's start off with Lyme disease. So Lyme disease is caused by Borrelia burgdorferi, and that's a funny name, but I always seem to remember it. I don't know why. It's transmitted via the Idoxes ticks, and it's commonly found in the northeast and upper Midwest of the U.S., especially Connecticut for some reason. The patient has a history of hiking outdoors or exposure in grassy wooded areas. And really the presentation is broken up into stages. So stage 1 is really early or localized. And you're going to see that classic erythema migrans rash. It's bullseye rash with viral-like syndrome, fever, fatigue, malaise, myalgias. Stage 2 is early disseminated. And you're going to see arthritis, myocarditis, or bacterial facial nerve palsy, or a bilateral facial nerve palsy. Stage 3 is going to be late disease. We're going to see chronic arthritis and chronic encephalopathy in these cases. So diagnosis is really based on exposure, history, clinical presentation, and we confirm it with the ELISA followed by Western blot. So treatment for Lyme disease is going to be doxycycline for adults and amoxicillin for kiddos and pregnant ladies. Appropriate tip really is bilateral Bell's palsy is almost pathognomonic for Lyme disease, and we always want to treat empirically if our suspicion is high. Here's just a picture of our favorite little tick and the different stages. This is also the areas of the United States where it's most often found. Here's a little bit in further depth of the 3 stages of Lyme disease, but we kind of already talked about those. Moving on to primary syphilis. So syphilis is caused by Treponema pallidum or T. pallidum. It's a spirochete. It's transmitted sexually or transplacentally. And primary syphilis is going to be a painless punched out genital ulcer or chancre at the site of inoculation, so usually on the penis. Diagnosis, we can do a dark field microscopy. That's diagnostic for the lesion. And a treatment is really a single dose of the IM benzathine penicillin, or PEN-G. And even in penicillin allergic patients, after desensitization, this is still the best treatment. So appropriate tip here is syphilis is painless ulcer. That's your buzzword. All right. As far as secondary syphilis, so again, most commonly caused by the T. pallidum. Secondary syphilis develops usually 5 to 8 weeks after the initial infection with a diffuse rash involving the palms and the soles. They'll also get some lymphadenopathy and condyloma lata, which are flat gray plaques. The diagnosis is really made by VDRL or RPR screening and confirmed with the FTA ABS. As far as treatment, it's the same as primary. We want to give the benzathine penicillin, and we want to give it IM times 1. appropriate tip here, if you see a rash on the palms and the soles, you want to think secondary syphilis. And remember, this type of rash might resemble pityriasis rosea, so take a good sexual history. Tertiary syphilis, let's see if we have that here. No. So I guess it might kind of mention it in this area. So tertiary syphilis, don't really mention it too much here, but really it involves gumas, aortic aneurysms, and neurosyphilis, and with the tabes dorsalis. And it's treated also with IV penicillin G down here. All right, moving on to the viral diseases. This is the last category, so I'm excited. We're doing really well. We're moving through this. Let's keep going. So we have cytomegalovirus is the first one, otherwise known as CMV. It is a herpes virus that usually remains latent unless the immune system is compromised. So we see this often in HIV positive patients with a CD4 count of less than 50. So pretty sick HIV patients. Presentation, we see retinitis with some floaters, blurred vision, blind spots, sometimes progressing to blindness. And the fundoscopic exam shows a pizza pie or a cottage cheese and ketchup lesion. And I think they have a picture of that here. This is your pizza pie or cottage cheese and ketchup lesion. The diagnosis is made via serology or PCR, and the treatment is by ganciclovir or valganciclovir. Appropriate tip here is if you have a patient with HIV and vision changes, you want to think CMV retinitis until proven otherwise. Right. So congenital CMV infection, you look for this classic rash. It's a blueberry muffin rash. You can see that down here. You'll also notice some microcephaly, and some hepatosplenomegaly seizures, retinitis, hearing loss, and treatment is again with ganciclovir and valganciclovir. So here's some of the things that it can cause. All right. All right, so next up we have infectious mononucleosis caused by the Epstein-Barr virus. Everyone knows mono. We covered it in the ENT section before, so this should be a quick review. So most commonly caused by Epstein-Barr virus, it's transmitted through saliva, hence the kissing disease, right? Presentation, we're going to see the fever, sore throat, posterior cervical lymphadenopathy, which is key, and fatigue. And on physical exam, we often see splenomegaly or hepatosplenomegaly. Diagnosis really by heterophile antibody or monospot testing or an elevated atypical lymphocyte on CBC. For treatment, it's really supportive care only. We want to avoid ampicillin and amoxicillin, which can cause a distinct maculopapular rash. One pro tip here is no contact sports for 4 to 6 weeks because of risk of splenic rupture. So we want to make sure that we document that and tell our patients that. Moving on, we have fifth disease in erythema infectiosum. So this one causes that classic slapped cheek appearance on the rash. So commonly caused by parvovirus Me19. Presentation usually starts with a mild flu-like prodrome, and then they get the slapped cheek appearance on the cheeks, followed by this lacy reticular rash on the trunk and the extremities. Complications can cause aplastic crisis in patients with hemolytic anemia and hydrops fetalis in pregnancy. So appropriate tip, if you see those bright red cheeks and a lacy rash, think fifth disease. Okay. Moving on, we have Herpes Simplex virus. We have the herpetic gingivostomatitis. So this is most common manifestation of primary herpes, and usually HSV1 around the mouth. Move these out of the way. I don't know why those are there. It's most common between 6 and 5 years of age. Presentation, you'll see this grouped group of vesicles in and around the mouth, and they are on an erythematous base and they can ulcerate. The diagnosis is really made mostly clinical, but you can do a PCR or zinc smear showing a multinucleated giant cells. And the diagnosis, or the treatment, is by acyclovir, valacyclovir, or famciclovir, and also supportive care if it's mild. Here's herpes labialis. It's really similar to what we just covered. This is more so in like adults via HSV type 1. They'll get these little clusters of tender vesicles and erosions. Again, the zinc smear with the multinucleated giant cells. The gold standard for diagnosis is going to be a tissue culture with PCR. and a topical or oral acyclovir is usually used. Next up, genital herpes. So genital herpes is a painful genital rash. Usually see a group of vesicles, shallow cluster of vesicles in the inguinal region, as well as linguinal lymphadenopathy. It is pretty uncomfortable. Diagnosis, really, you can make it clinically by sight, or you can get multinucleated giant cells on a Sank smear. And again, gold standard is going to be that PCR. However, you don't always have to do it. Acyclovir is going to be our treatment of choice. All right, moving on, we have herpes simplex keratitis. So herpes simplex keratitis is reactivation of HSV on the ophthalmic branch of the trigeminal nerve. Remember, cranial nerve 5. You'll get these sort of pseudodendrites, I guess, if you have the zoster ophthalmicus, which usually affects the ophthalmic branch of HSV. If you have herpes keratitis, you'll get these true dendrites, and they're visible on fluorescein stain on the eyeball. Treatment is really going to be topical or oral antivirals, but you never want to use topical steroids. And really, they need to see an ophthalmologist to get that checked out. If you see a lesion on the nose, that's Hutchinson sign, think that it could be in the eye as well. So refer them to ophthalmology. HSV encephalitis is usually caused by HSV1 reactivation involving the temporal lobe, so usually involves the temporal lobe. Presentation, they're going to have fever, altered mental status, and seizures. And the diagnosis is going to be via MRI. It's going to show the temporal lobe enhancement, and CSF might show some lymphocytic pleocytosis with an elevated RBC count. As far as management, we want to do IV acyclovir immediately. Appropriate tip here is really temporal lobe findings plus RBCs in the CSF equals HSV encephalitis. And it is the most common cause of non-epidemic encephalitis in the United States. Next up is Herpetic Whitlow. Herpetic Whitlow is a painful vesicular infection of the finger. It's caused by HSV1 or 2. It's pretty common in healthcare workers that are exposed to saliva or secretions without using gloves. You don't want to IND these vesicles. You want to always wear gloves when examining oral lesions because herpetic whitlow is highly contagious. And we want to treat with acyclovir if it's bad. If not, it's pretty usually self-limited. You don't always have to treat with medication. All right, here's HIV. HIV is pretty intense, so you do need to spend some time going over it in more depth. I'm just going to cover the highlights. So human immunodeficiency virus, or HIV, infects the CD4 T cells. And this leads to progression of immune dysfunction. And for screening, we want to do it with a 4th generation antigen antibody combination test. Diagnosis is confirmed with HIV-1 or HIV-2 differentiation immunoassay, and the treatment is going to be antiretroviral therapy or ART therapy. I don't think it goes into any more depth than that. This is kind of all that they have here, but I think you should know a little bit more. One other thing to mention here is that ART therapy is a combination therapy for all patients, regardless of their CD4 count. As far as prophylaxis is concerned, there's several different infections that we need to prophylax against. So a CD4 count less than 200, we want to prophylax with Bactrim for Pneumocystis jirovecii pneumonia. If we have a CD4 count less than 100, we want to use Bactrim, which also covers toxoplasmosis. And then if we have a CD4 count less than 50, we'll need to add in azithromycin for MAC. Appropriate tip really for HIV is know your CD4 cutoffs, and those are really classic board questions. Influenza, the flu. I'm sure we've seen it out in clinic. It's caused by influenza viruses types A and B. So presentation, you'll get this abrupt onset, like a truck hits you. Fever, myalgia, headaches, malaise, a non-productive cough, fatigue. And the diagnosis is made via rapid influenza antigen testing or PCR or a viral culture, but I see them do the rapid test more often. Treatment is going to be supportive care mainly. If you have a patient within the first 48 hours and they're higher risk, you can start them on the oseltamivir. Otherwise, it doesn't really provide much benefit after 48 hours. And here's some of the symptoms in a nutshell here. So these are the vaccine recommendations for influenza, who should get them, who shouldn't. And then here's the different drugs that are given for influenza. I see oseltamivir used way most often. Moving on to measles or rubeola. Measles, they are caused by the paramoxyvirus, spread via respiratory droplets. Presentation is going to be fever, cough, coryza, and conjunctivitis, followed by those classic Koplik spots or tiny white lesions in the buccal mucosa. They also might have a diffuse maculopapular rash spreading from head to toe. And the complications of this are really encephalitis or pneumonia. If you see the Koplik spots before the rash, you want to think measles. And we have seen lately, because due to unvaccination, there have been some outbreaks, isolated outbreaks of measles all over the United States. So we're going to look for that classic cough, coryza, conjunctivitis, the 3 C's, the Koplik spots, and the descending rash. Mumps. So mumps is caused by paramoxyvirus as well. It's spread through respiratory droplets. Presentation, we're going to see swelling of the parotid glands like this, parotitis, fever, malaise, and sometimes orchitis or aseptic meningitis. Really, it's the most common complication in adult males, orchitis, so swelling in that area. It's usually self-limited, and we don't do much for it. We just kind of provide some supportive care. But if you see parotitis and orchitis, think the mumps. Rabies. So rabies it's kind of scary. You don't survive if you get rabies, but it's if you get rabies and you're not treated appropriately. I guess I should clarify, but it's caused by the rabies virus. It's transmitted via animal bites, especially dogs, bats, and raccoons. The presentation is really pain, paresthesia, and hydrophobia, which is the intense fear of water, which is kind of crazy to think about. Treatment: you want to immediately cleanse the wound if you're bitten by one of the animals here on this little list. And you want to receive the rabies immunoglobulin and the vaccine series. So you'll get vaccines at days 0, 3, 7, and 14. You want to definitely make sure that these patients get treated appropriately, because rabies, if you don't treat it correctly, is fatal. And here are some of the more common types of animals that we see that have it. So as you can see here towards the top, dogs can be pretty bad, like raccoons, foxes, and other kinds of animals like that are bad. Bats. And then as we get further down, it's a lot less common to see it in like rodents and livestock and things like that. If the animal is a bat, even without a visible bite, you should probably give the vaccine. All right, roseola. So this is caused by the human herpes virus 6 or HHV6. You just see it in kiddos less than 2 years of age. They get really high fever for about 3 to 5 days, and then the fever resolves, and in comes this maculopapular rash. Usually starts in the trunk and spreads to the extremities. This is so classic. My daughter had it actually right around the time that she was getting her baptism, when she was less than a year old, and it was so classic. She had such high fever, and we couldn't figure out why the fever. And then a few days later, the fever went away, and she got this rash. So this is a pretty classic presentation. Moving on, we have rubella, German measles. This is caused by rubella virus. It's transmitted via respiratory droplets. As far as presentation, we're looking for a low-grade fever, sore throat, headache, posterior auricular and occipital lymphadenopathy. And they get this kind of pinkish maculopapular rash that spreads from the face down to the trunk. Complications are the congenital rubella syndrome, which causes sensory neurodeafness, cataracts, and cardiac defects. You got to be really careful with this, especially with first trimester pregnancies. And appropriate tip: if you see posterior auricular nodes and a pink rash, you want to think rubella. All right, another herpes on the list. This is Herpes Zoster or shingles. This is reactivation of the varicella zoster virus. And it's usually along a dermatomal distribution, meaning it picks a nerve and it kind of hangs out on that one side of the nerve. I think, yeah, there's herpes zoster. It comes from chickenpox. So first, I guess we should talk about that. Chickenpox caused by the varicella zoster virus. Presentation for chickenpox is fever, malaise, and a vesicular rash. You'll see them in various stages of healing, and they usually refer to them as dewdrops on a rose petal. So if you see lesions in multiple stages of healing, think chickenpox. Now, as far as herpes zoster, chickenpox lays dormant on a nerve and comes to life later on, comes out of hibernation. They get this painful vesicular rash that's usually limited to one single dermatome, and it's usually preceded by a burning or tingling in that area. Treatment for this is going to be acyclovir, valacyclovir, or famciclovir. Usually we want to do that within the first 72 hours. And that'll help get rid of it faster and help reduce the post-herpetic neuralgia. Vaccination is indicated for our elderly patients. And remember, we're looking for that dermatomal distribution that does not cross midline. If they have that plus pain and the little vesicles, it's shingles. So herpes zoster ophthalmicus, we kind of mentioned it a little bit earlier when we talked about herpes simplex, keratitis. This is a little different. This is reactivation of the varicella zoster virus in the ophthalmic branch of the trigeminal nerve. That's a V1 distribution. Again, if we see vesicles in that area or on the tip of the nose, that's considered Hutchinson sign. It is highly likely that there could be some orbital or ocular involvement. So we want to treat with oral antivirals and do urgent ophthalmology referral. All right, let's move on. Ramsay-Hunt. So Ramsay-Hunt is herpes zoster oticus. So this is reactivation of varicella zoster virus in the facial nerve or the vestibulocochlear nerve. So presentation is really ear pain, vesicles in the auditory canal, facial paralysis, and sometimes they'll even get vertigo or hearing loss. So treatment, we want to use acyclovir plus prednisone. That'll help kind of reduce some of the inflammation in that area. Pro PA tip, if you have ear vesicles and facial paralysis, you want to think Ramsay-Hunt. All right, we are at the end. That wraps up our infectious disease high yield review. So every major topic we covered from this Rosh guide and a few extras from start to finish, which is a lot to cover, I know, but I'm glad we went through it. We've covered bacteria, fungi, parasites, viruses, you name it, we've covered it. And these pathogens are the ones that come up on the PANCE PANRE and in real life clinical practice. So remember, we want to focus on patterns, which are like infections linked to immunocompromised patients, or the ones which are vector-borne, or which have those can't miss buzzwords like a bullseye rash, or slap cheek appearance, rice water stools, or dewdrops on a rose petal. Appropriate tip, really the best way to master infectious diseases is to connect the organism to the exposure history and then the signature symptoms. And once you recognize that little triangle for each of these, you'll ace the questions and the real patients. So I want to thank you for tuning in. If you found this review helpful, don't forget to check out the rest of our clinical medicine brief series, our Pro PA podcast, where we cover things in little bite-sized nuggets. And this will just help you out, making sure we cover the most high yield of things as you're getting up to your testing days. So thanks again. I appreciate it. Let me know if you have any questions in the comments below, and I'll see you next time.